Okay, our lecturer of today has contacted us. He will be there in 2 minutes, but we will start with our introduction video and the first case scenario of our course. Hello, everybody, and welcome to Masterclass ICM 2025. Everyone who's in Europe, a very good evening. The rest, hello again. And we will start with the first introduction video, which will introduce the case and the scenario to everybody. After this, we will hand the word over to our today's lecturer.
Mhm. 911, what's your emergency call?
Hello, he was just a big car accident and the man is screaming, he's in so much pain, you must
Ma'am, please come a little bit down. Where is the emergency?
I was just driving right out of I think it's I'm not sure. The man drove full speed against the tree, it's a big crash. He is conscious but he can't really talk to me. He's just in so much pain, please come.
University Hamburg Pharmaphone.
Hello, Miller, emergency doctor vehicle. I have to activate the trauma emergency room. Who will bring you a correct patient? Mr. David Johnson, born 1975, was involved in severe road traffic collision. He has no A, no B, severe C problem, no D, no E problem. We just started our ride. We'll be in the emergency room about 5 minutes.
Okay, see you.
See you.
So, hello everybody. Okay, hello everybody. My name is Dr. Smith and this is our patient, Mr. Johnson. He's 47 years old and he has been involved in a multiple car motor vehicle accident. He was buckled and all airbags opened, but his car was severely deformed. He had no A, no airway problem. He had no B, no breathing problem. We excluded pneumothorax on both sides using ultrasound. C, circulation. He was hypotensive with a blood pressure of 90 to 30 millimeter mercury and a heart rate of 125 beats per minute. He had a large hematoma on his thorax and belly on his right side. D, disability. He was fully alert with reactive pupils and a normal motor response on both upper and lower extremities. E, exposure. He has a femur fracture on his right side and multiple cut wounds as well on his right side. He gets one infusion line on the right side and we administered 1000 milliliter normal saline. Analgesia was performed using 25 milligram esketamine and 4 milligram midazolam. Tranexamic acid was administered in a dosage of 1 gram. Okay, any further questions?
I repeat.
All right, this was the introduction to our first patient. And now I will hand over the word to our today's lecturer, Tobias Witter. And maybe Tobias Witter will say some words again.
Yes, hello everybody. Hi, Tobias. Welcome back to Masterclass. It's a pleasure for me or for us, for the Masterclass team, to welcome Tobias Witter for the second time in this year, 2025. Tobias Witter is an associate professor at the Department of Critical Care, Anesthesia and Perioperative Medicine at Halifax University in Canada. Welcome, Tobias. Sorry for our delay. It's a technical problems. Welcome back to our masterclass. Your topic is polytrauma and hemorrhagic shock. Thank you so much that you are part of our masterclass team this year as well. Let's start.
I'm sorry about the technical delays. I'll just try to get going and share my screen with you guys. 1 second, and then we'll get right into that. Can you guys see my screen yet? Probably not. Where is it? There we go. Okay, can you guys see it?
Yes, it works.
Perfect. All right, and thanks for rolling the video already, so that makes it a bit easier, so we can skip that. So welcome from Halifax. We'll talk about hemorrhagic shock today a little bit, and about some other, and amongst them some other things. First of all, I need to say thank you to a couple of my colleagues who helped me out with some slides and some information. Where are we? So we are out here in the very eastward side of Canada. This is all Canada, and we are at the very east side of Canada, and not a very well-known province, I think, Nova Scotia. We have about 1 million people here. It's about 550 kilometers from north to south, from here to here. Takes you about 7 hours to drive. And what I want to ask you guys in my first question is, what is Nova Scotia known for? Do we have the highest heights in the world, the tallest lighthouse in North America, the longest beach in North America, or do we claim that hockey in Canada, hockey means ice hockey, is born and was invented in Nova Scotia? Which one of those? And I think there should be a, no, the Slido didn't start. Anyway, sorry. Take your guess. We do have the highest heights in the world here, up to, what's that? Up to 16 meters between ebb and flow, and it's quite something. And as you can see, leads to being boats sitting dry on ebb, and then leads to these pictures here at times. You've seen the video. I'm not going to repeat it for the sake of time, and we're already a little bit delayed. So we'll just skip that. My question for you is, is this patient in shock? And I don't need an answer from you right now. Think about what you saw. Think about the information you received. And if you say yes to the question, think about why you say so. If you say no to the question, think about why you say so. So we'll talk a little bit about trauma and hemorrhagic shock. Objectives for our talk today is we'll briefly go over the types of shock. We'll try to identify patients who are at risk, and we'll talk about an initial approach to hemorrhagic shock. We'll describe contributors to trauma-induced coagulopathy, and then we'll rationalize some hemodynamic goals. And then at the end, if you have time, we'll talk about some of the challenges we have locally here. Define shock. Start presenting, just play the poll. So should be able to answer that. Can you guys use the Slido? Let me know.
Yes, you need to wait a little bit of time.
Yeah. I'm just wondering if it's showing up and if people.
Yeah, it should be showing up.
Okay. Then I'll wait. Give it another 10 seconds. I don't see any results yet. Anyway, so definition of shock is ultimately an imbalance between supply and demand at the basic level. So we have an inadequate supply to the demand that our body needs. This is a very toyish picture of how our cardiovascular system works. We have some sort of cardiac output. The cardiac output pumps the arterial oxygenated blood around our body with a certain oxygen content. And then it is being transported to our tissues, and there we have some oxygen consumption. And we'll talk a little bit more about that. And then it goes back to the lungs, where it's getting reloaded with oxygen, and then that train starts to do this loop again. If we want to do a little bit of math on that, our oxygen delivery is ultimately calculated by our cardiac output times our oxygen content, which you just saw, the train times the amount of carries that the train is. The cardiac output is defined by stroke volume times heart rate, and the stroke volume is determined by preload contractility and afterload. And the oxygen content is mainly determined by hemoglobin and saturation. The dissolved part of this equation is under normal baric circumstances neglectable. So hemoglobin sats and then cardiac output determines ultimately our delivery of oxygen. In a normal state, we have a huge surplus of oxygen delivery. So the ratio of delivery to consumption is at normal rate at rest, usually 5:1. If you're hypermetabolic, we can still maintain that. And we only really get into trouble when we go down to our venous sats to 50% and our extraction ratio of 2:1. So for the most part, we are at a very stable equilibrium between supply and demand and don't run into any major issues. But these things can go awry, and then we have an imbalance between supply and demand. And again, we can compensate for a long period of time. So our oxygen delivery and our oxygen consumption is over large ranges, delivery independent. And therefore, but as we get closer to the threshold, our central venous oxygenation goes down, oxygen extraction rate goes up. And then when we cross that threshold, our lactate will start to climb. And at that point, we become delivery dependent, or our O2 consumption becomes delivery dependent. Just as a reminder, we generally talk about 4 different types of shock. The most common one is actually distributive shock. On an average ICU, about 60% of the ICU admissions are accounted by distributive shock. The most common one is septic shock. The others, hypovolemic and cardiogenic, are roughly equal, about 18% each. And then the obstructive shock is a rare form, but always on our differential list. So coming back to our trauma, when we have this trauma, and as you saw on the video, that there's a huge team expecting that patient, and to activate this team, which is resource intense, and if we have it, it's good for patient outcome. But it is a bunch of resources that need to be there. Everybody needs to let everything else go that they're doing, walk down and receive the trauma. And to activate that, there's criteria. In our center, and it's pretty much, I think, roughly the same across the world, we have physiologic criteria, meaning that the blood pressure is low, that we have ventilatory problems or whatever else. We have anatomic issues, meaning loss of limb, for example. We have a spinal cord injury, and so on and so forth. We have mechanisms, penetrating injuries, gunshot wounds, ejection from a car, for example, would be one. Logistical, sometimes, especially when you have multiple people there, you just need the additional resources and activate it. And then last but not least, at the discretion of the trauma team leader, they can activate if they think it's indicated. In outpatient, we at least have 2 activation factors available. We heard that his systolic blood pressure is a little bit low, so that would warrant an activation of the trauma team. But also, we have a mechanism. While it's not specifically listed here, we heard from the emergency physician and from the paramedics that the car was significantly deformed, the airbags were deployed, So we can assume that there's a certain amount of force, or that the patient has been exposed to a certain amount of force, and therefore we activate that trauma team. So 2 reasons in this case. And when we activate a trauma team, it often looks like this, that there's a bunch of people there sitting or standing around the trauma and trying to do their best to help this patient. And we'll see if it goes this time. What is very important in this particular setting when we think about the image that you just saw, and what do you think is important? I don't think the Slido works, to be honest.
It works fine for us. We can even see on your shared screen the answers that we type.
Really? That's
Yep.
great because I can't. That's fantastic. I'm glad that you have the answers. Perfect. So obviously I can't comment on the answers because I can't see it. Anyway, the important thing is that there's no I in team. So it's a trauma team. It's not a trauma individual looking after these patients. And whenever there's a team involved, we need to make sure that we have a good way of communicating very important information. And that is important for the people who provide this information, so they can stick to a certain routine, but also for the people receiving information, that they know what to expect from the person handing over. One of the acronyms that is used for traumas is MIST. And I'm going to use this here, that there might be others out there. MIST stands for Mechanism, Injury, Signs and Symptoms, and Treatments. The mechanism in this case was that it is a motor vehicle accident or a motor vehicle collision with multiple vehicles. The driver was restrained, speed is unknown, the airbags were deployed, significant deformity to the car. So that's a significant mechanism of injury that can cause severe damage to our body. The injuries that were identified by the team at the scene were bruising on the chest, potential bruising to the abdomen, questionable pelvis fracture, or questionable long bone fractures. The vital signs are as stated here, and GCS, we haven't really formally assessed it. We'll get to that in a second. And what has been done so far is that the patient has been extracted from the car. IV access was established, C-spine was fixed. He did get some fluids and a little bit of analgesia and sedation, and he got a gram of TXA. When we then assess the patient in our trauma bay, as was done by the team in the video, we follow the ABCDE sequence. We talk about airway, we talk about breathing issues, circulation problems, disability. So what's the neurostatus, and then there we come back to our GCS scale as is shown here. And then lastly, exposure. Are there any other major injuries? Is there a piece of metal sticking into that patient somewhere that we haven't seen yet? We roll him over on the back, make sure that there's nothing in the back, and so on and so forth. And it's really important to do that, to really take a look under the hood, making sure that you don't miss any obvious open fractures in the femur or tibia, and don't overlook these injuries. Using the ABC approach in our patient, we can assessment. We can say the airway is clear. So far, he's been verbalizing and no obstruction of the airway. Breathing sounds clear. Pneumothorax has been ruled out by ultrasound at the scene. His rest rate's at 24 at the moment. He has a blood pressure of 90/3, heart rate of 25. He's alert oriented. We don't know how many times, but he seems to be knowing some things. Pupils are equal and reactive to light. He's moving all extremities. No loss of consciousness at the scene as far as we know. And we know from our exposure that there's a significant hematoma on the right chest and abdomen, obvious right femur fracture, and then multiple lacerations. So that would be our primary assessment. And then the next question, since we're talking about hemorrhagic shock, is this patient in shock? And maybe somebody can let me know the results. We'll give it 15 seconds or so to my question here. Right. Gonna see.
Nearly 100% for yes, Tobias.
Okay, thanks. All right, so 100% say yes. How do we determine that? One simple method is using the shock index, and shock index is defined by heart rate over systolic blood pressure, and if that's over 1, then there's a very high probability that they're patient shock. But it also, in trauma patients in particular, predicts the need for massive transfusion and potential further management of bleeding. Whenever we talk about massive transfusion in shock, one rule of thumb is hypotension in the trauma patient is, until proven otherwise, caused by bleeding. And therefore, we need to have a rough idea what bleeding or massive hemorrhage actually means. And there's a bunch of definitions out there when you go and look at the literature or the guidelines. One definition is blood loss exceeding 1 blood volume over 24 hours. Practically, that's not really super helpful because we want to know now if this patient is actually at risk or is actually bleeding. The other one is blood loss over 50% in 3 hours, which is also not really very helpful because, again, we don't want to wait 3 hours, then estimate what the patient's blood volume is, and then see what's on the floor and see what's in the sponges and whatever else, and then calculate that. More timely definitions are blood loss over 150 mils per minute with hemodynamic instability. And personally, I like this one probably the most. That there's an internal trigger that if you need more than 4 units of blood in an hour, then probably you have a problem. Keep in mind that those definitions are nice, but for the majority, these definitions are used for research and studies only. The practical application of those is not really great, to be frankly honest. The last one may be useful, or the second last one too, to activate a massive transfusion protocol. But really, nobody is sitting there and saying, okay, now we are at 49%, so we can't do anything. Now we're at activate a massive transfusion protocol. Another way to predict if the patient should be on the alert scale for massive transfusion is if there's at any point during that whole course a hypotension of a systolic blood pressure of less than 100. That predicts, again, massive transfusion needs, high transfusion requirements, further interventions very well. Similarly to what we talked about earlier, shock index and that systolic blood pressure of less than 105, you can use the ABC score, which is comprised pressure less than 90, a heart rate above 120, a positive fast and penetrating injury. If you have 2 or more of those things positive, then again, you have a 75% rate of requiring massive transfusion. So how do we deal with this guy, with this patient? There's a traditional ABC approach. And as an anesthetist, I like to deal with my airway. So I like you better when you're under general anesthesia, and I like to intubate. And therefore, I want to do this early because then my job is done and I can just sit there and watch the other people do the work. This used to be the approach, but it may not be the right thing to do anymore. In early phases of these traumas, we have, or in many shock phases, we have what's called sympathetic excitatory phase, driven by release of catecholamines from the adrenal gland, stimulated by the pituitary gland. And they pretty much keep us alive during these periods because they generate the compensatory mechanisms that we need to perfuse our vital organs in those settings. They increase our heart rate, they squeeze our blood vessels, and make sure that we, again, focus our cardiac output on the vital organs like brain, heart, kidneys, liver, and so on and so forth. And that's part of the reason why clinically these patients are all, when you touch them, they're all cold, clammy, and just feel not nice, because they are focusing or redirecting the majority of their blood flow to the vital organs. However, this sympathoexcitatory phase doesn't last forever. It's going to give way to the sympathoinhibitory phase, where the central stimulation by the pituitary gland goes away. We do no longer release the amount of catecholamines we have released before. This is partially compensated with an increase in vasopressin release, but it doesn't overcome the decrease in sympathetic drive that we
Mach dir mal die Tür zu.
by the
Ich verstehe sonst kein Wort.
catecholamine release. So what that means is that from the initial vasoconstriction that we see in our blood vessels, we slowly move to vasodilation over time, and that is suboptimal. On top of that, we have what's called shock-induced endotheliopathy, that the more severe our trauma and the more severe our catecholamine surge is, the more damage we do to our endothelium. We rip it off, we damage the glycocalyx, and with all of these things, we generate microthrombi and capillary leakage, and so on and so forth, potentiating the vasodilation we already have centrally, now peripherally, and making the situation worse. So if we consider intubating these patients early, because we just want to do it, we may actually make matters worse, because with our drugs that we're going to use for induction of these patients, we accelerate that transition from the excitatory phase to the inhibitory phase, and potentially cause more harm than good. So maybe what we need to do is we need to resequence our resuscitation efforts. And while we all like to intubate, at least me as an anesthetist, I like to intubate, early on, securing the airway may not be the right thing unless you have a strong indication to protect the airway, because the airway is failing. In our patient, when we reassess him now, a couple of minutes later, the airway remains clear. Now we have diminished breath sounds on the right, and our respiratory rate has gone up a little bit. Blood pressure is a little bit lower than it was before. Heart rate's a bit higher. He becomes more agitated and restless and erratic. And now has chest pain and crepitus and abdominal tenderness. We also figured out that he has an unstable pelvis and a deformed femur. So my question to you is, I have a list of a bunch of interventions. Which one of these interventions is currently the most needed?
As nearly the half identify bleeding source and the half decompressing the thorax.
Okay.
Securing the airway 10%.
All right. Both are great answers. In this case, again, when we look and think a little bit about our A, B, C, D, E, the airway is clear, but it may deteriorate at some point. Maybe he has a TBI, maybe we're going to give him some medication, who knows. But currently, there's no intervention needed from an airway point of view. Breathing, we certainly have clinical evidence that there is either a pneumothorax or hemothorax or a pneumohemothorax. So decompressing the chest is probably not a bad idea. With our blood pressure dropping and our heart rate going up, certainly there seems to be bleeding going on somewhere. And again, until proven otherwise, hypotension, the trauma patient is bleeding. So we certainly need to go on the hunt for that. The patient becomes agitated and restless. Again, could be a worsening TBI, but could also be caused by the increasing respiratory distress that the patient subjectively feels with his impaired lung function. And again, all these areas, unstable pelvis, deformed femur, abdominal tenderness, chest pain, all of those are very reasonable sources of bleeding. So there's when we talk about trauma, and we're looking for bleeding sources, or if the patient's bleeding, we look on the floor and there's 4 places more. So you can use that little saying to figure out where the patient is bleeding from. So obviously, if there's blood on the floor, we have a problem. But where are the other 4 places that we should look to figure out if this patient has a significant bleeding issue?
So most, both for abdomen, pelvis, and chest.
Pelvis and chest. Excellent. These are all pros, Tobias. No, can't teach them anything. Sorry. So there's the FAST protocol, which is the most commonly used, but there's tons of others, iterations of that out there. It doesn't really, they really don't differentiate each cell from each other that much. Anyway, what we look for is we look at the right upper quadrant. So we look at the liver and we also look at the chest. And we want to make sure that the Morrison pouch is empty so that there is no black fluid between liver and kidney. You're going to do the same on the other side. Look at the chest, look at the spleen. And hopefully there's no fluid between spleen and kidney on that side. Here, this space doesn't have a separate name, I think. And then we're going to look at the pelvis, the Douglas pouch down here, see if there's any fluid around the bladder. And many of us also look at the heart, see if there's any pericardial effusion or anything there in that area. This is how the liver ultrasound Morrison pouch looks like. You can see that there's no black fluid between the liver and kidney. And on the other side, on the spleen, looks a little bit murkier, but we can potentially make out that there's a little bit of fluid collection behind the spleen or between diaphragm and spleen. So maybe this patient had a spleen rupture. Needs to be confirmed. So to standardize this search, or how we can approach figuring out if this patient is bleeding, there's a couple things. So if you have a blunt trauma, the first question we always have to ask ourselves is our patient currently hemodynamically stable? If the answer to that is yes, then we can do a FAST and see what we see on the FAST, and then plus minus a CT scan, and then based on those investigations, we can make a decision. Is the patient going to the OR? Is the patient going to the ICU? Can we watch and wait? Depending on what those scans show. But again, the major question, determining question here is my patient stable at this point? If the answer is no, you're going to do a FAST. And if the FAST is positive, the patient usually goes to the operating room. If FAST is negative, you have to figure out where the other bleeding sources are. And that may be in the chest, that may be in the pelvis, but ideally you will find that out on the FAST. Not going to go over all these other additional treatments, but main determinant is my patient stable? Yes, no. If my patient is stable, I do have a little bit of time, although they can deteriorate real quick. If my patient is not stable, we will do a quick FAST. If the FAST is positive, they go to the OR. Our patient now has a little bit of fluid in the chest, as we heard. So this is the diaphragm, this is the spleen, and this is the lung. And to address that and to potentially help reduce the distress of the patient from a breathing point of view, we're gonna do this. You can see that they identified the spots, they have a sterile area, and they find a needle in there, figured out that's the right area, they got blood back, make a nice incision, do a finger thoracostomy, release a little bit widening the space, and then they use a instrument to go to go in and spread the area. You can do that with an instrument in the field. You can also do it with a finger. It can be a hard job, especially in younger patients when the tissues are still fairly tight. And then once you're in the pleural cavity, you want to stick your finger in there and make sure that there's pleura all around. And you maintain the access, if you want to put it this way, and then insert the chest tube through the hole you just created. And there's a bit of blood coming out. And if you have nice shoes while you're doing that, I would highly recommend to change before, because there's a lot of blood usually dropping on the floor. I've ruined a few pair of shoes like that. And we hook them up to the Pleurovac or whatever system you have in your institution. And then you can see there's a fair bit of flow coming out already. And that would technically, based on what we discussed earlier, qualify as massive hemorrhage. At the end, you want to make sure that the tube doesn't fall out and secure it with sutures. And I've worked in a couple institutions throughout my career, and every institution has their own ways of, every surgeon has their own way of fixing their chest tubes, and so does everybody else. So there's not one way of doing it right. Just needs to stay in. All right. I think we can move on from there. So you saw what was coming out of that chest there. And again, there's different variations or definitions of based on how much blood we lose, can we classify them into certain categories of severity of hemorrhagic shock. This is the one from the ATLS Society. They say if you have 15% blood loss, it's a class 1, 15 to 30, and so on and so forth. Pulse rate, similar to the shock index and the ABC index we talked about earlier, goes into this a little bit. Pulse pressure, often difficult to assess in those acute settings. Pulse pressure is the difference between systolic and diastolic pressure. Blood pressure overall, again, we use that in the shock index already. Rest rate, as we saw earlier, the sicker the patient gets, the higher the rest rate is. Mental status, sometimes difficult to assess in these settings because many of these patients are intoxicated or under the influence of drugs. Urine output, in my opinion, not a good parameter, especially early on, because it takes a little bit of time to actually assess, and there could also be injuries to the urinary tract that prevent the patient from having urine output. So not sure how useful this classification is. Again, many of these classifications are mainly for research purposes or practically not very often used. Nobody stands in a trauma bay and says, oh, we have a class 3 hemorrhagic shock, we need to do ABC. What does a bottle of scotch and blood loss have in common? So if I open my bottle of scotch here and I measure the alcohol content, it's going to be 55%. Similar to hemoglobin, if I draw hemoglobin from me right now, it's whatever, going to be 160 or so. Then I finish my bottle of scotch, almost drink it down to here, and I measure my alcohol content again. and it will still be 55%, despite the fact that my bottle is almost empty. Similarly to bleeding, acutely, when you bleed, you measure my hemoglobin now before I bleed, and I lose 2 liters of blood, and you measure the hemoglobin, it will still be roughly the same. So hemoglobin levels are not very helpful in early trauma or in early hemorrhage to determine of how much blood you have actually lost. They only become relevant further down the road when we have done resuscitation. So that's why you didn't see it in the ATLS classification, because it's not really helpful early on. More helpful than that might be base deficit, because base deficit is an expression of the metabolic demand that we have, and in this case, metabolic acidosis. And there's a strong correlation between base deficit and units of blood being used, or massive transfusions and mortality. So Mutschler proposed a new base deficit-based classification of hypovolemic shock or hemorrhagic shock based on the extent of deviation of the base excess from normal, which again physiologically makes probably more sense than the classification above. So where are we at the moment? So we went over criteria for activation of trauma team transfer to trauma center. And my assumption is that they're pretty much roughly the same around the world. There's handover protocols, which standardize the communication between the sending or the handing over team and the receiving team. There is an approach that we always assess and reassess and reevaluate the sequence, and we can use the ABCD approach for that. We have a couple of early predictors of shock and the need for massive transfusion, the ABC score, shock index, and so on and so forth. You can use those to be on alert and potentially have a low threshold to trigger massive transfusion protocols. And there in every institution, there are pathways of how do we diagnose severe bleed and what the actions are that come out of that. Earlier I said positive fast goes to the ER. There might be centers who send them to interventional radiology first, depending on the bleed. We do that more and more as well in our center. But again, that's why these protocols are great and these pathways, so that there's not a huge discussion every time a trauma comes in, what are we doing next? So, provocative question, who cares? Why do we bother about this? Why do we talk about hemorrhagic shock in the first place? Trauma is the #1 cause of mortality in ages 1 to 44 worldwide. Exsanguination is the #2 cause of trauma mortality. Non-surgical trauma bleeding, so
Mr. Witter?
can fix, can be
Mr.
very
Witter?
impressive, and therefore we need to go and talk about that a little bit more.
Mr. Witter, we have 2 questions in the chat.
Yeah.
The first question is, would you prefer BE over lactate to determine the extent of the shock? Maybe you want to answer one by one.
Say that again. The first question is,
would you prefer base excess over lactate to determine the extent of the shock?
They go hand in hand. The base excess is often driven by the lactate, so you can do both. And again, I wouldn't necessarily categorize them in hemorrhagic shock 1, 2, 3, 4. It's more an expression of the severity, and naturally, the more you deviate from baseline, so the higher your lactate, the more negative your base excess is, the more severe the shock form is. So for me, they're equivalent roughly. And again, a lot of the negative base excess in these acute trauma patients is driven by the lactate.
The next question is very similar, but I will speak it out loud to you, everybody. What advantage is in this setting does base excess have over, say, lactate, or did we just find out empirically that base excess is a better indicator?
I don't think there's any superiority. it also depends a little bit on what you have available for point of care testing in your center. If you use, for example, iStat, there's some iStat modules that do lactate but don't do basic SAS and vice versa. But again, coming back to the first question, the basic SAS, the negative basic SAS, is mainly driven by lactate in those settings, therefore you can use either or.
Thank you very much.
No problem. All right, so trauma again is number one cause, and bleeding is the second most common reason for why they die. When we look at mortality of patients, the first couple hours, I would say until hour 4 or 5, is mainly the mortality is mainly driven by exsanguination, so meaning blood loss, and part of that blood loss is tri-induced coagulopathy, which we'll talk a little bit more. This is how they sometimes look like, right? As time goes on, initially we resuscitate a little bit, everything looks nicely, we put our bags down, everything's cute, and then after 6, 7, 8, 9, 10 units, it becomes a chaos, and then we just throw the bags on the floor, but also our resuscitation gets a little bit more chaotic.
Ja, aber ich weiß nicht, ob ich so lange das durchhalte.
Another question, or are we good?
No, there was no question. I think there was a microphone not muted.
So trauma mortality is also directly associated with coagulopathy. So you can see that while with the increase in your injury severity score, the patients with additional coagulopathy on arrival had a higher mortality, and it directly correlated with the injury severity score versus the patients who did not develop a coagulopathy. While they still had a high mortality, it wasn't as bad as if you had a coagulopathy. What we usually do is we have a vessel injury, there's a vessel spasm initially, and then there's platelet adherence, and we form a clot, including fibrin binding and stabilization, and then the hole is sealed, if you want to put it this way. In a little bit more detail, when we have an injury to the endothelium, platelets adhere to the subendothelial factors, tissue factor, and thrombin gets activated, and they activate the platelets through this chain over here. And the adherence is down here with the collagen and the platelet receptors. Then von Willebrand factor and glycoproteins on the surface of the platelets mediate further binding of the platelets to this. And activated platelets then release ADP and thromboxane A2, which then bind and activate other platelets in the vicinity up here. And these activated platelets express glycoprotein 2B3A, and they capture fibrinogen. And with fibrinogen being transformed into fibrin, they then start to form a clot. Intrinsically, also mediated by activated thrombin, we have an escalation cascade. So a little bit of thrombin activates 8A and 5A, and at the same time 11A, 9A, 10A. That leads to a huge amplification of thrombin, and then thrombin splits fibrinogen into fibrin and makes sure that the clot is getting stabilized and firm. So that's what usually happens. If our patient, however, is hypothermic, we can see that specifically for fibrinogen, our synthesis is down. Breakdown is not so much impacted by hypothermia, but the synthesis of fibrinogen is severely decreased. If our patient is acidotic, we can see that the synthesis is not as much impacted, but the breakdown is significantly higher if our patient is acidotic. In net, what we can see then is we have, from a fibrinogen point of view, hypothermia leads to a lower synthesis rate and a higher breakdown rate. That's for fibrinogen. When we look at thrombin, again, the main clot enzymes are activated thrombin and fibrinogen that we need to form a clot. And the other factors are important too, but those are the major ones. So thrombin kinetics, this is our normal control curve over time. And we can see that hypothermia impairs it, acidosis impairs it. And when we have both together, it's really, really bad. These findings lead to the well-known triad of death, if you want to put it this way, in trauma patients of hypothermia, acidosis, and coagulopathy. As you all know, this is the textbook picture from how our clotting cascade works. And I want to bring your attention to that little thingy here, that's everywhere. So calcium is a very important cofactor in pretty much every step of our coagulation cascade. And therefore, people expand the triangle or the triad to lethal diamond, and including hypocalcemia into that. So, and we need to really pay attention to that, to our calcium levels during these resuscitation phases, that we don't deplete the storages of calcium, because many of the blood products we give either have citrate or EDTA in, which are calcium binders. So they take calcium out of the circulation, and therefore our clotting cascade can no longer work. You've seen part of this picture earlier already, or at least a different graphic, where we have our shock-induced endotheliopathy, and it gets worse. The worse the shock is, the higher the catecholamine surges. This is all driven by neurohumoral factors and endothelial damage. What we also get in that setting is that our TPA release from tissue is significantly going up with severity of injury. And TPA is plasminogen and can lyse the clots, which is not helpful in that setting, because we are really struggling to form clot. And in our normal body, they are in balance. So we form clot and we break the clot down. But in trauma, we really want to form clot. And a huge burden of TPA does not help, because it breaks down all the clots that we just formed. So that's the rationale for using tranexamic acid in trauma patients. That goes back to the CRASH-2 trial, which one of the largest trial in that area, with over 20,000 patients. There's a bunch of caveats about the trial, but bottom line is it showed that we may get a benefit in severe trauma patients. And more importantly, there was no harm. So giving a trauma patient TXA is a relatively benign thing if we give it early, and potentially leads to better outcome. So when we look at coagulopathy, we can pretty much break them down into two major things. We have a quantitative coagulopathy, meaning we have a lack of factors. And the lack of factors is either due to dilution, because we give our patients a bunch of crystalloids and they bleed, and therefore we dilute the coagulation factors that are remaining in our body, or we consume them. So that leads to a quantitative coagulopathy, meaning we don't have enough clotting factors in our system. We also have a qualitative coagulopathy, meaning that anticoagulants, acidosis, shine, hypothermia, and acidosis contribute to the qualitative coagulopathy, but they also will influence to some extent the quantitative coagulopathy through fibrinolysis. Hypothermia and hypoperfusion through all of that doesn't help. So that's a rough overview over what's going on. If you want to read more about it, Transfusion Ontario has a really nice pamphlet. It's free, it's online. Just go to Transfusion Ontario, and they have nice pictures in there as well, and explain that a little bit more. This is a picture of a young guy, and I think you see the picture of the older version of this guy. And my question is, who is it? Did we get an answer?
Not yet.
Not yet.
But 4 people are typing, so we just have to wait a moment.
All right, we'll give those 4 people a chance.
Might I
I
just
have no
interrupt
idea.
and ask a question? Would that be possible?
Say again?
Might I then just use the time to ask a question? And the administration of tranexamic acid obviously has been shown not to be harmful, but what are your thoughts on delayed thrombolysis through that? Because then when you look at the patients, like when you do clotting assays on them, you obviously see that in the patients who didn't receive tranexamic acid and like, let's say healthy, that they at some point also have the healthy thrombolysis again, which is then massively delayed in the patients who did receive TXA. Do you think that could be a problem as well, which we then induce in our patients? Because then obviously that also delays microperfusion then at some point.
So if I understand you correctly, you were asking if the effect of TXA will cause a downstream effect to the perfusion of the tissue. Is that what you're asking?
Basically, if you see like any harm in the delayed effect.
Yeah. It's not been reported. So there's a couple of things. TXA is not a fix-all, right? We have data for trauma patients based on the CRASH-2 trials. There is some data for orthopedic surgery and whatever else, but there is no evidence, for example, if you give it in GI bleeds or whatever, so that it does anything good. The caveat would not be so much that I'm worried about the microcirculation being impaired by it. The caveat is more, do we impair the thrombolysis to the extent that we have a larger clot formation somewhere else and we get MIs or PEs from that? And that has been shown in some subsets of patients, not the trauma population as far as I know. But overall, and that's why I said this, when in that acute setting, we haven't seen a signal that it causes harm at this point. And TXA has a relatively short half-life, so it's not going to be there forever and cause problems for further down the road. Does that answer your question?
Thank you. Yeah, it does. I think it's one of those things where then just in future we'll see what happens.
We don't necessarily want to give TXA over and over and over again. We do if they keep ongoing bleeding and whatever else, but then you probably have a bad prognosis for your patient in the first place. But we don't want to give it, every 3-4 hours. You give it once, see what the effect is, maybe give it again, but then you're pretty much done. Okay.
Yeah.
All right. Did we figure out who this guy is?
No, unfortunately, no answer. Sorry.
Okay.
Yes.
This guy is Wayne.
Sorry.
No, just can you tap back one slide, because 16 people answered, but there you can, now you should see it.
Wayne Gretzky.
Right. So I can't give a talk from Canada without mentioning Wayne Gretzky, probably the greatest hockey player that ever lived. Anyway, what he said, and is a good hockey player plays where the puck is. A great hockey player plays where the puck is going to be. And I like this statement because it applies to massive hemorrhage as well. Massive hemorrhage management medically is not difficult. Blood out, blood in. We need to make sure that we tweak things a little bit. The difference, the difficulty in massive hemorrhage, from my point of view, is you need to anticipate what you need in half an hour. You need to anticipate which blood products and what you want to do in half an hour, and need to get those blood products there, or order them now so you have them in half an hour, because some of those blood products have a lead up time and you can't get them right away. So that's, in my opinion, the challenge in massive hemorrhage. Second pause. So what we learned from the last couple of minutes is that we want to avoid acidosis, we want to avoid hypothermia, we want to avoid coagulopathy. We don't want to treat coagulopathy, we want to avoid coagulopathy, because coagulopathy is associated with worse outcome. We give TXA early, and to the question from earlier, the data is within 3 hours of trauma. Don't forget the calcium. Calcium is a very important cofactor. And again, from a management point of view, anticipation is key. You need to know what you need in the future. Moving on. So now we have our patient in the trauma bay. We figured that he's bleeding from somewhere. Do we need to send him to the OR? Maybe. There's this concept emerging in the last 10, 15, 20 years, damage control surgery, that puts physiology over anatomy. I remember when I was a resident, and which is longer ago than I'd like to admit, but we took patients to the OR, and the surgeons try to fix everything. They try to, make the anastomosis, fix the liver, take the spleen, and whatever. They try to fix it. We moved away from that because the patients were too long in the OR, were difficult to resuscitate, and we never got the bleeding under control. So this is where this concept of damage control surgery emerged. So we're going to initially use the best hemostatic agent we have, which is pressure. So we hold pressure, and we potentially go to the OR and make sure that all the big vessels are sewed over and fixed. And then we pack, give the patient time, stabilize, optimize the milieu, make them warm, fix the acidosis, give them clotting factors, and then take them back 24, 48 hours later and see what else is going on and fix the rest of it. During the early phases, pressure is our best hemostatic agent, so we need to apply pressure. Then we have a couple hours when they go to the OR where we suture things up. And then we really need to fix the coagulopathy over the next couple hours. And this is where death rate from exsanguination drops below that of CNS injury, which is then the determining factor of outcome. So we need to give our patients blood, and sometimes a lot of blood. And to be able to do that, we need to have good access, meaning we need to have decent size IV access. And we'll learn in the next video what that actually means. So we're giving 500 mL of Ringer via different types of catheters. And you can see we have a 24 gauge over here. We have an 18 gauge. We have an 18 gauge central catheter, which is longer than the 18 gauge IV. That's actually an IO, sorry. We have 14 gauge IV, and we have a Sheldon catheter, which is dialysis catheter. With 12 gauge, but also a little bit longer. And you can see the flow rates, the fill rates in the bottom there. Dialysis catheters do great. We have 500 mL in after less than 4 minutes, followed by the 14 gauge peripheral IV. The others are still running, I can assure you. And they all go in under pressure, by the way. And next one is the central venous catheter, 18 gauge, 416 seconds. And I'm taking bets, which one is next, and then last one will be the 24 gauge IV, which is pediatrics, to be honest. All right. So large bore IV, ideally short catheter, generates a high flow. And what do we give our patients? We always talk about balanced resuscitation. So again, coming back to the concept, we're losing blood, we're giving blood, we're reconstituting blood. There's a motion now in some studies in trauma centers to actually give whole blood. I think we're getting closer to having the storage figured out and being able to give that. In our center, we still give components. So we give packed out blood cells, plasma, platelets, and potential factors. And we're trying to reconstitute a 1:1:1 ratio, so for whole blood. Rule of thumb is think 3 ABC. So after 3 units of blood, activate massive transfusion, give balanced resuscitation, and don't forget the calcium and other concentrates. So you can use that think 3 ABC as a guideline as to what to do. And then what you'll see now is a massive transfusion device, which can help us in those settings, because we can run a whole lot of blood through, or a whole lot of fluid through a device that not only puts it in under pressure and puts it in fast, but also warms it up. And therefore we avoid hypothermia, which, as we learned earlier, is not great in that setting. So you can see how quickly this runs in. And the important thing about that is, coming back to anticipation again, what I said earlier, whenever you use a massive transfusion device, these things are able to give a lot of fluid in a very short period of time. Particularly when you give blood, you need to have almost 1 or 2 people dedicated to run that device and hang the bags, take them off, put the next one up, and so on and so forth. Check the blood bags that is the right blood for the right patient, and so on and so forth. So again, this is a resource intense scenario, and if you are in that situation that you have to run massive transfusion with a level 1 or Belmont device, then you need people to operate that thing so you can deal with other tasks. So in our patient, now that we're in the resuscitation phase, maybe in the OR, which blood pressure should we target? And I think I gave a couple parameters there.
%, to be honest, for a map of about over 65 millimeter mercury.
Okay.
80%.
Above 65. Okay.
Yes.
All right. So first question is, should we target systolic or should we target MAP? Depends on what you're looking for. The systolic target is interesting because we have this philosophy that we don't want to pop the clot. So if our systolic blood pressure rises, then the clot that has been formed may potentially be popped off and the patient starts to bleed again. However, from a perfusion point of view, when we look at organ perfusion, we're looking at a map, because the map is what the organ actually sees and is being perfused, and then at the end we have the CVP. So from a perfusion point of view, map is probably the better target. Should we use cuff or Artline A? First of all, you need an Artline for being able to use it. If you don't have an Artline, you're going to use the cuff. If you have both, the question is always, which one should we trust? Which one should we use? And there's a nice paper that looked at that. And ultimately it says, if you use systolic versus Artline, the SBP is underestimated by 10% by the cuff. And then if the systolic is less than 60, it's overestimated by 10. The good thing is the maps are the same. And that's another reason why a map is probably the more robust parameter in those settings. So coming to our actual parameters, there's this concept of permissive hypotension, and that goes back to a paper by Bickel, published, I think, to around 2000 or whatever. And they say that when we delay fluid resuscitation, except permissive hypotension in penetrating trauma, the survival is 8% higher. Numbers needed to treat were 13. When we look a little bit more into the paper, the differences in systolic blood pressure, one group was 58, the other one was 59 at the seam, so not really that much different. On arrival in hospital, it was 79 versus 72. Also not that much different. And overall, the difference was 2 liters of ringers that one group got and the other one didn't. Once they hit the OR, the management was exactly the same and the numbers were the same. So you can argue that's a great paper, and if you should base decisions on that paper, particularly since follow-up trials over the next 20 years pretty much showed no benefit of that concept of permissive hypotension. That's part of the evidence. The European guidelines say for trauma resuscitation say we should target a MAP of 50 to 60. So they adhere to that permissive hypotension concept, although I think it's been debated if that's actually still a good idea. And they also say systolic blood pressure 80 to 90. So if you said earlier target a lower MAP than what I usually would target, you were in safe range based on the European guidelines. Is there potential harm if we go hypotensive? Well, if we have an associated brain injury, our mortality is potentially significantly higher if we follow those lower blood pressures. Brain injuries are classified into mild, moderate, and severe based on their GCS at presentation. And mechanisms are often with the coup is where the injury happens, and then the contracute because the brain bounces back and forth. And we can have multiple different bleeds. We can have subarachnoid bleeds, which we see fairly common in trauma. We have epidural or subdural hemorrhages as well. And then we can also have interparenchymal hemorrhages that can cause problems, mainly the frontal lobes, we see those. In general, in our brain or in our skull, we have three things at baseline. We have brain, hopefully. We have some blood, arterial and venous, and we have CSF, 10%. As we have lesions coming, either tumors usually grow, slowly growing, so there's a little bit of shifts, but if we have a hemorrhage, then that will take space and push these other areas out of the way. And the main thing that goes out of the way is the CSF. As the real estate in our skull is limited, in the beginning, when we have a little bit of a bleed, our compliance curve just goes up a little bit. But as we move up this compliance curve, our pressure in our skull goes up significantly and then causes shifts and potential herniation of those patients. But also, as the intracranial pressure rises, it means that our perfusion pressure, so the blood flow to our brain tissue goes down, because our cerebral perfusion pressure is determined by our mean arterial pressure and our ICP. And the minimal threshold is probably set somewhere around 60 to 70 for TBIs, for traumatic brain injuries. And so we want to be above that 60 threshold of CPP, not MAP, CPP for those brain injuries. Therefore, this is coming from the European guidelines. For trauma patients who have an associated brain injury, we want to target a MAP of above 80. And that's pretty much standard across the world, I would say. So, having heard all that, should we use vasopressors in shock? Because the concern is that if we use pressors, we're going to make the bleeding worse, and therefore we need to give more blood products. What do you think? Should we give pressors in hemorrhagic shock or not?
About 60% for safely blood pressure into target range. About 40% could be used to keep blood pressure up when TBI is present.
Okay. So, pressors in hemorrhagic shock. Again, remember the beginning of the talk. We talked about this vasodilation, that we shift from the sympathetic excitatory phase, where we have tight vessels, to the inhibitory phase, where we have some vasodilatation that's aggravated by endotheliopathy. Also, there's this thing called neurogenic shock that in itself is a distributive shock form and can cause vasodilation. So if we give 8.4 liters, outcome is the same. So there's no detriment in outcome in that setting. There's a saying here in North America, Levophed, Levophed. Levophed is the trade name for norepinephrine. So Levophed, Levophed So no increase in mortality when Levophed or when norepinephrine is used in blunt trauma. So I think what we can say is that we can safely use vasopressors if we target a certain range and don't overshoot in trauma patients. Why should we? Coming back to my anesthetist roots, I want to intubate, right? So I want to put the tube in. And the problem that we talked about earlier is that if we don't resuscitate our patients first and prepare for it, we see a post-intubation hypotension rate of over 33%, so 36% in trauma patients. And those patients who are hypotensive have a double mortality rate compared to those who are not hypotensive post-intubation. So it does matter if you do your job well in the beginning, making sure that you resuscitate your patient, making sure that you have vasopressors ready when you intubate, and avoid that post-intubation hypotension, choose the right drugs. So again, our RSI that we often use in trauma patients needs to be resequenced a little bit. We need to optimize the patient first if we can. If there's an airway issue, we obviously need to secure the airway. But if we have time, we optimize the patient and then use a hemodynamically safe approach to intubate our patients. So how to play nice in the trauma sandbox? For TBIs, we target a MAP of 80 to 85. For hemorrhagic shock, MAP over 65, I think is reasonable. In some settings, you want to just keep it above 50, but for my patients, I would target a MAP over 65. If you have both, the TBI trumps the other guidelines, and you go to a MAP of 80 to 85. So let's see how our patient is doing.
Here we see Mr. Johnson, who's 55 years old and came to us 2 hours ago. If you come around, you can see on his left side that
Mr. Miller,
Yeah.
we could change temporarily to the other video. We got the one who's a bit louder and has subtitle. 1 second.
You want to do that? Then I stop share my screen.
Yeah.
Good.
Welcome back to the ICU. Here we see Mr. Johnson. He's 47 years old and came to us 2 hours ago due to a car accident. If you come around, you can see on this left side that he's got a chest tube. As well as an edema on the left side of his abdomen. You can see 2 external fixatures as well, one on his pelvis because of a pelvic type B fracture, and one on his femur because of a right side femur fracture. We're going to check for free fluid in his abdomen every 8 hours. As a matter of fact, we're going to do it right now. So we've taken a look on the spleen and we can see no free fluids. We're going to check again in 8 hours.
Perfect. Give me 1 second. Oh, I need to share my screen again. Oh, I'm lost. Shouldn't have done this. 1 second. Yeah, that was pretty much it. I want to talk a little bit about the challenge. Can you see me? Or can you see my screen? You can probably see.
Yeah, could you change? We just see the presentation mode on our screen now.
We only have three slides left. So What I mentioned earlier is Canada is a big country, and as I said, from the South Pole part here, Yarmouth to Sydney, it's about 7-hour drive. It's about a 45-minute flight from Halifax to Sydney, and about 35 minutes from here to there. So what I'm saying is we don't have a high density of hospitals that can deal with that patient population. Ultimately, in that whole area, we have one hospital, which is here in Halifax, that deals with all of that. That is also true for PEI and parts of New Brunswick. This is our catchment area. So keep in mind, 45 minutes flight radius to get us here. And during that whole time, the patient needs to be stabilized. That's a challenge. When we look at Canada as a whole, about 90% of the population lives in the first 100 kilometers from the US border. So everything above this artificial line here is only populated by 10% of the patient of the population. We are in Nova Scotia. If you take a patient from Inuit, which is up here over Yellowknife to Edmonton, which takes care of this whole catchment area, you're looking about a 4-hour flight, one way. So again, I remember times when I flew in Germany, we were in the air, and within 10 minutes, we had 4 universities hospital within our reach. So it's easy to drag these trauma patients somewhere and then say, we'll bring them to hospital, they will be taken care of. Here, due to geographical challenges, this is not as simple. And there's other pieces or parts of the world where this is similar. There's logistical issues that need to be addressed before we can take care of those patients. In summary, hemorrhagic shock has an early high mortality, so that's why we need to address them early and aggressively. Treatment and management is a team effort. You cannot do that by yourself, and therefore, medication is needed. Hypertension trauma patient is secondary to bleeding until proven otherwise. In that patient population, we should use blood products early to make up for the losses, but also replenish our clotting potential. We can adjust our blood pressure targets, and we should potentially individualize them based on what we have in front of us. And at times, not so much for Germany or for Central Europe, but there are areas in the world where it's difficult to access the patient, and even if you can access, extraction might take a long time. And that's all I have to say. Happy to take questions.
Okay. Thank you so much, Tobias, for this nice presentation. Before we have the opportunity to answer several questions, we have a video, right, for obviously a visit of the intensive care unit directly after admission of Mr. Johnson.
Who's bringing up the video? You?
Steve?
Sorry, I didn't get you.
So we have a video for the visit of the intensive care unit after admission?
We saw it already.
Okay, this one, the next one is on Thursday. Okay, so we have to have opportunity to answer the questions. Considering the long...
I can see some questions. Should we use vasopressors? Yes or yes, you should. If indicated, and at least my practice is, I'm curious what you did, Tobias. Whenever I intubate somebody who's borderline, I make sure that the presses are hooked up and running potentially, just to counteract that potential hemodynamic deterioration. So short answer, yes, presses should be used and should be ready. Do you differentiate MAP and SPPT between trauma types, blunt penetrating TBIs? Yes and no. So I do target, if I have a TBI or in general for every brain insult, we usually use the pop the so we want to keep our systolic blood pressure lower, whatever that is, sometimes 160, sometimes 140, sometimes 120. And then we want to make sure we set a perfusion target of above 65 for the most part. So that's how I usually use these two parameters. If I'm worried about bleeding or rebleeding, I put a ceiling on my systolic, but my main target is my perfusion, and that should be above 65 somewhere. Considering the long flight times, do you feel there's a mortality difference? Yeah, there is, because again, having done rescue in Germany and being involved here, there's a selection in Europe, or here, sorry, there's a selection here. There's many people who die on the road that we simply can't get to in time. Versus in Europe, we were able to get there in a reasonable amount of time, dragged into the ICU or to the hospital, and then deal with them there. So I think there's a selection to some extent that favors those short out of hospital times or short patient activation to patient contact times. When should we use ROTEM? You will hear all about ROTEM in the other talk, so I'm not going to comment on that. Do you think the concept of damage control charter should be adapted for non-trauma hemorrhage shock, such as postpartum? Yes. And that's what commonly happens. I think it emerged from the trauma population, but for example, our liver transplants sometimes come to us and they're not done because they ran into bleeding issues. They put the liver in, make sure the liver is perfused, but bile duct is not hooked up. So they go back, they're being packed, they go back 24, 48 hours later for completion of surgery. That also is true for other surgeries, ischemic bowels, for example. While they don't bleed, they don't know if the bowel is viable. They leave it in discontinuity and then go back 24, 48 hours later to see if that works. So yes, this concept is being used in other areas as well. Are there limitations? There probably are, but I have to think hard to find one at the moment to this concept. To be clear, European guidelines prefer permissive hypertension 50 to 60. Yes, that is the current guideline. And unless Tobias, you're aware of an update on that, but I don't think so. I haven't seen anything.
Okay, any further questions?
Yes, if I may. You earlier on talked about an arterial line and central venous axis. Just in your institution, just on your own, like now eminence-based opinion, do you find that there's significant loss of time when you put in the central venous axis and put in an arterial line if you have a critical patient that needs to go to surgery, like to the theater immediately? Or do you feel like it's a bit of like playing about if you don't just rely on like, let's say 2-3 large peripheral cannulas and just a normal nip cuff?
I'm not sure there's a black and white answer to that question, to be honest. A lot of that is circumstantial. Ideally, you want to monitor your, from my point of view, my opinion is I'd rather have an art line than a central line in this setting. Because I want to get arterial gases, I want to see what the patient's acid base status is, or lactate is, hemoglobin, and so on and so forth. If I can get a bunch of big IVs in and have an art line, then I'm happy to take them to the OR. There we can do further management, and there shouldn't be that much delay in putting a central line into somebody like that, maybe 10 minutes or so. But my preference is good IV access first, then if I have time in that context, art line, and then central venous access or larger access for massive transfusion catheter or whatever else, dialysis catheter, whatever you have, to actually run the resuscitation. So that would be my sequence of events. But again, this needs to be adjusted based on circumstances, based on urgency of RR, based on personnel available, and so on and so forth.
Thank you.
You're welcome.
And last question.
There is one in the chat,
Must-
so, and then plasma transfusion is being done while blood is pouring out, I was assuming. Could we do TXA more often? You probably can because you dilute it for sure, or you lose it again, yes. But I'm not aware of a fixed formula of that. But you can guess if you give TXA now, then you lose 5 liters, then you can give another bottle of TXA. Similar with antibiotic dosing or stuff like that. If you lose your blood volume and you replace it, there's probably nothing left of the drug in your system.
Okay, I think that's all.
Yeah.
Again, Tobias, thank you very much for your support of our masterclass in this year. Thank you to all for participating in our course. In the next week, we're going to proceed with fluffy stuff and viscoelastic testing. And we'll talk about with Frank Chege from London Air Ambulance and David Schmidt from Saarbrücken Intensive Care Unit. Thank you so much to you all. Have a nice evening, afternoon. Good night. See you next week. Bye-bye.
One moment,
Oh, sorry.
please, for the
Sorry.
participants. Julian has a short update concerning Amboss.
Thank you, Ludger. That's important.
So let's talk about Amboss. We've contacted them, and they had their technical team fix the issue. So they found out what the issue was actually. It was on their side, considering the service or whatever. And it should be working for everybody now. Please make sure to contact us if it doesn't work for you. Otherwise, please remember that we do have a course prepared for you. I'm gonna send a link in the chat right now so you can access that one. Thank you.
Thank you, Julian. Okay.
Have a nice evening.
Bye.
Okay, if you have any further questions or problems, please contact us in our chat in WhatsApp group. Okay. Thank you, Julian. Bye-bye. Thank you, Tobias.
Bye, Tobias. Ciao.